The topic that we had contemplated before was around SI joint treatment, evaluation. That topic is of special interest to me just because I've done a ton of work around it. So I thought one of the interesting things we could talk about, and I know you weren't on the recent call, but it was something Adam brought up about sort of the foundational knowledge or some standardization of what we expect our providers to have as they launch into treating things. And I think the SI joint's kind of an interesting arena because it really is treated by many of us in different fields, but probably with a bit of a varied understanding. Even orthopedists really came to that field late. It was sort of an ignored pathology for decades of orthopedic surgery until the 90s, I think. So I thought we could just start with that principle of understanding the joint and maybe build into evaluation of it. So what are your thoughts about that? What are your thoughts about, what you'd expect a provider of treatment of the SI joint to have in terms of knowledge base and training on evaluating the joint, understanding the biomechanics, that sort of thing?
Yeah. So my thought process would be that there's a significant misunderstanding of referral patterns of pain that leads to misdiagnosis, especially around the sacroiliac joint. A lot of practitioners are not aware that it can radiate as far as the ankle. Often the initial perception is that it must be a radiculopathy, and they'll go down a nerve root decompression pathway. And then the patients often will, after treatment, will have persistent symptoms. And then later on, it gets identified that the sacroiliac joint was the symptomatic issue all along. And so I think getting them to understand that there is going to be overlapping patterns of pain, and they should include this as part of the workup at the beginning would hopefully lead to better outcomes.
That's a great thought. You bring up an interesting point, and one of the things I've struggled with the SI joint, particularly post-COVID, is at least where I am, a great deal of my pain management colleagues have moved to telehealth. And as you probably are aware, the SI joint is uniquely requiring of hands-on to be diagnostically, not necessarily suspected, but certainly moved up in the differential considerably, as you just mentioned, because there's many things that can masquerade or be similar to it in the way it manifests symptomatically. How do you feel like our telehealth realm has maybe challenged us to be astute in picking that up as a diagnosis, or at least moving towards it more swiftly?
Well, I think physical exam is a key component to arrive at an accurate diagnosis. So going to a telehealth approach and also becoming over-reliant on imaging may lead to these issues. And so I'm a big fan of the old school approach of actually getting hands on the patients.
Agreed. What do you think about the training on physical examination? One of the folks I worked with a long time in interventional was a radiologist. He was a great interventionalist, but it was pretty clear to me that he didn't really have the training on sort of the clinical side, the physical examination, to pick up all of these things, test the hip, test the stroke bursa, test the SI joint, all the things that require physical exam. And, that doesn't take anything away from his ability to execute the techniques of treatment. But in this particular case, what do you think are the sort of the basic rigors of training people to do the physical examination maneuvers that both include and exclude the SI joint and look for all the other pathologies that can be similar or masquerade?
Yeah, there is significant variability in how these exams are performed for each specialty. And I think it may be worthwhile for each academic institution, for the leaders of the different training programs, to talk about how to more standardize the physical exam approach out of these overlapping specialties, whether it's interventional pain, PMR, surgery, neurology, et cetera.
Yeah, I totally agree. We talked about on our last call this possibility of establishing a bit of a fellowship training program of some sort that we conceptualize would involve sort of a multidisciplinary center, a center of excellence in our view. This came to mind, this sort of issue came to mind to involve the surgeons and the physiatrists and the interventionalists to really make sure that those individuals that are considering these diagnoses have the training on the physical exam and the acumen to pick things up that really can masquerade as SI joint or vice versa. And so I think this fits with what you're saying, that wherever they're treating SI joint pathology with injections or surgery, there needs to be a real focus on the examination and clinical acumen.
Yeah, we should be able to arrive at a similar diagnosis, even though we may try to approach the problem from different angles.
Absolutely. In orthopedic surgery training, as you probably are aware, we do a fair bit of biomechanical training, educational foundation of what we do, whether it's fracture care, joint reconstruction, spinal reconstruction, whatever. And certainly the SI joint has its own sort of unique biomechanics. How important do you think that awareness is at the basic science side of SI joint in managing the problem, managing the pathology? In other words, if we're invoking treatment options such as stabilization or fusion modalities, how critical do you think that understanding is before you render treatment?
Well, if you're going to evolve or expand your options to include some, whether it's a stabilization or a fusion technique, then you need to understand the principles of how to achieve that. There's out of the different systems that are being used to treat the SI joint, there's roughly, I think, 55 different companies now in the market, and the mechanics of what they're doing usually don't lead to fusion. I think there's very, very few systems that actually have a joint preparation component to lead to an actual true fusion of the joint. So most of the systems are either essentially pinning the joint or trying to place a wedge to try to stabilize it. And I think there's a significant misunderstanding of what the principles are to lead to a true fusion, even though every procedure is being built as a fusion procedure.
Right. Agreed. And what about just the aspect of the biomechanics of the joint? How does it move? What are the forces that it sustains in the course of normal life? Pathology that's cephalad to it in the spine or hips? How much of that do you think is pertinent in rendering treatment or managing the patient in a reconstructive way?
I think it's important to understand that to provide appropriate care. I think it's a little bit more forgiving for this particular target. You don't see as much adjacent level degeneration compared to, immobilizing segments of lumbar spine, for example. So you don't see that other complications of adjacent level issues, fortunately, as much for this particular target. And I think it's because it doesn't move that much in the first place.
Right. One of the data points that we've started realizing in the deformity realm for spine is that spinal deformity tends to yield higher rates of SI joint pain. There's a differential biomechanical load on the SI joint such that when we correct deformities, we can eliminate SI joint pain. So it does beg the question, and there's several questions that come out of that. When we see patients with both SI joint pain and significant deformities, what do we do? It's obviously relatively easy to manage the SI joint as a sole issue. May not deal with the deformity part of the equation, but it's a conundrum. What do you do with that situation where they have both issues going on? And then the follow-on question, which I wrestle with as somebody who does deformity surgery, how do we plan ahead if we have both things going on? And as somebody who's got to revise some of these cases, if somebody's fused the joint with metal construct, does it get in the way of what I need to do for the spinal deformity? The answer is often. It's obstructive and creates complication issues for the patient undergoing the deformity operation. So my sense is in those patients that have deformities, I think one of the things we need to really promulgate in education is there needs to be that collaboration between a deformity surgeon or spine surgeon and whoever's managing the SI joint reconstructively so they can plan ahead a bit like, and you may not be aware of this, in orthopedics and spine now have to work hand in hand with our joint colleagues that do hip replacements, because when we establish new alignment in the spine, it really can change the cup position, acetabular and femoral head position to the point where there's more frequent dislocations that can occur, which is obviously challenging for the patient. So it's that sort of forward thinking and multidisciplinary approach to a problem that we may both have to deal with in the future without burning bridges.
Exactly. No, I agree with that. And I think also that, if you're going to look at correcting the deformity first and assuming that there's a high rate of the SI joint becoming more painful later, do you also do some approaches to stress shielding of your lower part of your implant to perhaps address the SI issue at the same time.
Right. That's an ongoing area of research for us, to be sure. Do you have questions from your end on how surgeons think about it?
Well, right now, and you're seeing a lot of the evolution of the type of implants that are being offered from the original essential triangle shaped pins, and now the evolution of different types of screws, and then the systems that allow you to decorticate the joint. So any particular preferences that you have of what you've found based on your experience with these systems in terms of steps, do you find that, the decortication aspect would be an important component for this?
Yeah, it's an interesting question. I mean, the orthopedic sort of training in me has always been a little bit leery of not having something compressive, but I also understand the benefit of the stabilization of the joint over two to three spots ideally, because that's biomechanically superior to stabilize the rotational nature of that joint. Historically, I would have said that you have to fuse a joint. But now with the bioactive implants that we utilize in a variety of areas in the spine, inner bodies, within disc spaces and those sorts of things, and really on the heels of dental, total joint arthroplasty, like femoral stem implants for total hips, I've changed my opinion on that in terms of what has fortitude and durability. In a sense, if you've got on-growth, in-growth capability in a bipolar way, just as you get with a femoral stem, where you don't get a fusion, but you get this vibrant sort of living interaction between bone and implant that responds to stress, I think it is reasonable in either case. And it just comes down to data. What is the clinical outcome, both short and long term? What's viable on a long-term basis from an outcome perspective, and less important in terms of radiographic findings. So I really, my sense is whatever solution that you utilize, it's incumbent on us to really depend on good data for whatever solution you've chosen, and it's got long-term sustainability, much like we have to employ with fusion constructs.
Yeah, no, I think with the bioactive implants, that may reduce our need for the use of biologics. I can tell you just from experience having used systems where we were just placing screws alone versus screws with the decortication component, in terms of immediate post-op relief, I definitely see a significant difference amount of the reduction in pain. And I think with that decortication component, you're removing some of the nerve fibers in the joint space. I think that adds to the pain relief that we see early on.
That's interesting. Yeah, the biomechanical challenge with screws in general, and there may be a very small number of exceptions, is the sacral bone, which we have to work in all the time, is really poor. So you don't really get good fixation in the sacrum for very long, unless you're crossing two cortices. We do that in pelvic trauma, where we have screws that bridge sacroiliac joint to sacroiliac joint, but really they're accessing the cortex of the cortex of the bone on either side. But the sacral bone, in many of these cases, in the areas that we're trying to interface for mechanical fortitude, tends to cycle load pretty quickly to failure in sacral bone, just because it's pretty trabecular and soft. So that is the sort of challenge with standard buttress screws in the setting of the sacrum, not necessarily the ilium, but you got to have both sides to actually work.
And then maybe try to make up for that with length, because I think for every 2 centimeters additional length, you improve pull out by about 50%. So I think that's something else to consider in terms of how much length the implant is on that sacral side.
Absolutely. Although that length can be challenging to get in 2 to 3 spots. It's a good shot up above the S1 foramen. Below, you can often get one that's 2 centimeters for sure. What are your thoughts about, and I know it's sort of a charged issue because of the coverage, but for years and years, people did ablations for the SI joint, and those just generally aren't available from a pair perspective. What are your thoughts about ablation? Should that be off the table forever? The success rate was pretty poor, so I understand why, from a pair perspective, it really lost coverage. But what are your thoughts for the patient who otherwise is submitted to something surgical, which is obviously a big step to take, and they don't have that non-surgical approach at their disposal, whether it's hot or cold?
Yeah, so I would say it's unfortunate for the patients that we have a lot of patients who may not be good surgical candidates because of other comorbidities or just the relative obesity. They may have a good candidate, and to have another option provide them some relief. in terms of the results, I think it depends on the technique. There's a lot of different techniques that have been used for ablations, and often they don't take into account the variability of the distance between the nerve fibers and the sacral surface. So if you actually have a taller size lesion and it's more comprehensive, the results are usually pretty good for a length of time. I have several patients who've gone 6 to 7 years before asking for a repeat treatment. So I think if you do a more complete deinnervation, you can do a great service for the patients.
Do you think that the studies on it then need to be repeated by individuals that can do it at a higher level then? I mean, where are we missing the data and why?
I think if we redid some of those studies, but focus on a technique that leads to a more complete deinnervation, I think you'll probably have different outcomes.
Be interesting to revisit that. And on the side of injection therapy, we've heard this in some of our meetings. We'll see patients that have had, 50 injections, not 50, but a lot. What's your sense of threshold to say, okay, that's enough? How long should people get relief before they're considered for, a more definitive surgical intervention to stabilize or fuse the joint?
Well, I think you first have a conversation with the patient. What is a reasonable long-term plan? So after you've confirmed the diagnosis and you go through the different options that are available, whether they're covered or not, whether it's steroid injections, ablations, or going on to a fixation approach, and talk about the pros and cons of each. And on the injection side, you have to let them know about what are the side effects of steroids and too much steroids, whether it's increased osteoporosis, if they have a history of diabetes, what else is that going to impact? I think it's maybe for getting some immediate relief for someone that's really desperate. You can say, well, I'll offer you 1 or 2 injections to at least give you some time to think over what is a reasonable long-term plan. Repeated injections overall is not a viable option.
Got it. I had a patient recently come in who had confirmed SI joint pain and was interested in surgery, but their pain management provider never sent them to physical therapy. And as you probably are aware, about 2/3 of people actually respond favorably to physical therapy and may never need surgery. How do we educate our colleagues on both sides of the table to follow sort of a standardized algorithm for these patients, both for their benefit and also to avoid that angst that patients have going through half a dozen injections, fail those, then be sent to the surgeon who has to tell them, you can't even have surgery now because physical therapy is required for you to get authorization to have surgery. Should we be educating our colleagues in general in sort of a standard protocol for management before they undergo the invasive treatment, even if they're injections in the setting of SI joint pain?
Yeah, I would say that the education is always going to be something that I would promote. I think it's less of an issue compared to the past because even for injections, often the approval process or authorization process requires physical therapy within the last 6 months. So whether it's driven from knowledge from the physician or provider or insurance rules, I think the utilization of physical therapy has gone up.
That's good. All right. Last question I've got. There's been a striking increase in the use of allograft bone through the posterior medial approach without what I'll call compelling long-term results. I'll say sort of uncertain or questionable short-term results, but definitely no definitive long-term results. This has increased the utilization substantially to the point where it may create some challenges for the RUC committees and for the valuation of SI joint treatments going forward. What are your thoughts about that?
Well, it's a approach that often is misplaced. So I see a lot of cases for revisions, whether it's revising allograft implants or lateral implants that are placed very, very posteriorly. So they're not going across the main articular portion of the joint and then they fail. And with the allografts, I see a large number that are placed in the middle of the ilium or middle of the sacrum. So they're not in the joint space. And the ones that are in the joint space, they tend to resorb. So they may give you some immediate pain relief immediately after the procedure. And you'll see a lot of publications talk about 6 months of relief or so, but they really don't fuse the joint. And often they end up coming back for revisions. So I don't use them in my practice, but yeah, I think we really need to have the conversation about which devices or approaches have determined outcomes that are favorable and, looking at 2-year plus outcomes.
Great. Agreed. My thoughts exactly. All right. Well, that's all I got. Thanks for jumping on this morning.
Enjoyed it.
Yeah. Many more conversations to come.
Thanks. Excellent. Have a great day.